Hi, Professor Stanley here, and today I am back with a lecture on breast, axillary, and regional lymphatics. So let's get started. All right, I wanted to talk a little bit first about the changes that do occur in the body, and please review your anatomy and physiology in your book because that will help you to understand, anything that you don't already know about, you definitely need to review. So, first of all, estrogen hormones are what stimulate the breast changes that occur during the adolescent period, which includes, fat deposits, a duct system that's going to grow and branch off. And just so you know, this breast development, or thelarchy, precedes menarche, which remember that is your start of your period, by about 2 years. Now, gynecomastia may also occur sometimes in adolescent males, and it's usually a temporary state, but you can imagine how this could be a problem for a growing boy if his breasts are developing and, he may not understand that it's going to go down later and it's definitely going to cause some problems with body image. So that's something to be aware of. It also may reappear in the aging male. In the aging woman, the breast mass is going to decrease and the skin is going to lose its elasticity and droop and look flattened and flabby. This is going to make the inner structures more prominent because, now those areas underneath that were previously hidden will kind of be revealed by this flattened and flabby tissue that has less mass. And so you might see some underlying, even fibrous or even malignant tumors. And the lactiferous ducts are going to be more palpable, firm, and stringy also in aging women. Breast cancer is still very prevalent, with 1 in 8 women developing malignancy in their lifetime. And it is more treatable than it was previously, so the survivability is higher. And this is partially due to genetic prediction of breast cancer by looking at the BCRA1 and 2 genes and when there is a likelihood of mutation. There is improved treatment for cancer, and screening mammography does tend to identify this very early, which should begin about 40 to 44 years of age, unless there's somebody that's maybe a higher risk, then they would be earlier, and annually after 45 years of age. Risk factors for breast cancer include drinking. Even a few drinks a week, like the book gives 3 to 6, can increase your risk. Obesity, probably because of the higher estrogen levels that exist in fatty tissues. And regular physical activity is going to improve it, and maybe consuming high levels of fruits and veggies is going to improve it. But they said that there's not proof, it's just kind of suspected. Now, I'm not going to spend a lot of time talking about culture. You can find that on page 382 of your book. But we've already talked about certain people groups having less health-seeking behavior because of underrepresentation within the healthcare environment. And in these individuals, if they're not getting the screenings, then it's usually identified later. So you can imagine that they're going to have poorer outcome. I am also not going to spend a great deal of time on this objective today. You may look that up on page 382 and 3 and 4 of your book. These are the areas we are going to assess. As always, we're going to gather information on pain because we want to know, whether or not that's occurring. And there are some conditions such as mastalgia, which occurs with trauma, inflammation, infection, and benign breast disease. And mastalgia, algia means pain. Mast is referring to the breast. We're also going to ask about lumps because obviously we want to identify any sort of problems that may be malignant or a malignancy in the breast very early so we can begin treatment. And so a lump or thickening in the breast is something that we definitely want to identify so that we can refer out to get that evaluated. We want to ask about discharge from the nipple. When did they first notice it? What color is it? What's the consistency? And does it have an odor? We're going to want to identify any rashes that may be on the breast, in the skin area, or any swelling in the tissue or the breast. Is it in one spot? Is it over the whole entirety of the breast? When did it begin? Is there changes in the bra cup size related to this? All of these things. Is it related to the menstrual period? That could be, something that can occur as well. Is there any trauma that's occurred in the breast, and did it result in any swelling, or is there a history of breast disease? And would that be, you also want to identify if there's a history of breast cancer within the family because of the genetic predisposition of individuals to breast cancer. What type of breast disease was it? When did it occur? How is it being treated? And we want to know whether there's been any breast surgeries or radiation, such as a mastectomy, a mammoplasty, augmentation, or reduction. There can sometimes be problems that occur in the breast related to augmentation, depending upon the type of insert that's been used when somebody has their breast enhanced in size. We want to identify medications, whether or not oral contraceptives have been taken and for how long, because they do carry with them an increased risk of breast cancer. Whether or not there's been hormone replacement therapy, such as estrogen or progesterone. Of course, this may occur in menopause or in treatment for someone who is trying to get pregnant, and these can cause an increased risk of breast cancer. We also want to know about alcohol, as we already talked about. Even moderate or small levels of alcohol consumption can sometimes increase that risk as well. So basically, we're collecting any information that could be related to changes in the breast or a history that would predispose someone to have a higher likelihood of developing breast cancer. I also think it's appropriate for us to gather history in pregnant women, especially whether or not there is an intent to breastfeed, whether or not there's any tenderness and tingling, and also there is a higher likelihood when there is milk going through the milk ducts that someone might develop mastitis, which is a very painful infection that can occur in the breast tissue, and we want to identify that. It is going to be oftentimes needed to be treated with antibiotics. And so that's something that's important on screening of pregnant women. And of course, I'm sure you'll talk more about that in maternal child. And then in the postmenopausal woman, we want to ask about changes in the breast contour, size, firmness, and see if they've been noticed. And it may not be apparent, but it may be. And so that's important for us to identify as well. Next, we are going to inspect the breast tissue. And of course, some asymmetry is not an abnormal finding. Some people will have one breast that's larger than the other. But what we want to make sure of when this occurs is that it hasn't been like a sudden change in size. We're looking for edema, and no edema should be present. The skin should be smooth, even in color, no redness, bulging, and no dimpling, no lesions or focal vascular patterns or something like that. And stretch marks are going to be a normal finding in breast tissue. We are also going to inspect the nipples, which should be symmetrical and on the same plane on both breasts. And they usually protrude, but some are flat and some are inverted. If they are inverted, though, we do want to distinguish ones that are normally inverted from one that has become suddenly inverted. There's also something called a supernumerary nipple, which is not an abnormal, it is, rare, but it's not a terribly abnormal finding. And basically, it is like a smaller nipple within the same line that's going to be located about 5 to 6 centimeters below the breast, near the midline, but it should not have any sort of underlying tissue associated with it, so it's not going to have its own little duct system. It looks a little bit like a mole, but on examination, you will notice that it is an actual nipple. We are going to have our patient perform the retraction maneuver, and you can find that on page 387. It basically is where we ask them to change positions, where they lift their arms, and we're watching that the breast should move up together, and we shouldn't see any dimpling or puckering present. We're also going to have them place their hands on their hip. Again, we're looking for the same thing, that dimpling, puckering, or abnormality between one and the other, and have them with their elbows still extended, clasp their hands together in front. Again, we are looking for that puckering and that dimpling because that can show that it is fixed to a structure below it, such as might occur within a tumor. And then we're going to inspect the axillary region. We're looking at the skin. We're looking for any lesions, any areas of infection, and obvious areas of enlargement. And then we're going to move on to palpation. So in order to palpate, we are going to have the woman lie supine, and we're going to tuck a small pad under the side to be palpated and have them raise their arms over their head. If someone has large pendulous breasts, we may need to get them to rotate their hips to the opposite side. And all of this is done in order to kind of define that breast tissue on that side and make it easier to palpate and spot any problems. In order to palpate, we are going to use 3 fingers. That's going to be the index, the middle, and the ring finger, and the pads of those fingers. And we're going to use a light, a medium, and a deep palpation at each site as we follow a vertical strip pattern. And that pattern can be found on page 390 of your book and begins in the upper axillary region at the outside breast tissue. A woman who has not had any children is called, of course, nulliparous, and their breast tissue should be firm, elastic, and smooth. But after pregnancy, the tissue will be softer and looser. An inframammary ridge is normal, which is a ridge of compressed tissue that will be found in the lower quadrant of the breast, especially on women with a larger breast tissue. We are also going to depress the nipple tissue into the well behind the areola, and it should move inward easily. A pathological discharge from the nipple is going to be spontaneous, unilateral. It's going to have blood or is clear and serous. And we're going to note the number of droplets in the quadrant producing the discharge and blot the gauze, blot with gauze to ascertain the color and test it for blood. So, as we're depressing the breast, we may cause discharge if there is discharge that is occurring. We may palpate large pendulous breasts by having the individual sit and lean forward as we support the inferior portion of the breast with one hand and palpate with the other. If a lump is noted on any of these portions of the exam, we need to note the location, the size, the shape, the consistency, the movability, the distinctness, meaning is there one or multiple, the nipple, is it displaced or retracted, and the skin over the lump, is it red, dimpled, retracted, is there any tenderness, lymphadenopathy, is there any regional lymph nodes that are palpable nearby? And when we are looking at breast tissue that has signs of a more advanced cancer, we're going to use the acronym BREAST, which stands for breast mass, retraction, edema, axillary mass, scaly nipples, and tenderness. So that's what we're looking for in both the breast and the axillary region as we palpate throughout. I wanted to also note that you can teach women to do a self-examination to kind of keep an eye on their breasts in between these yearly exams, and you're going to teach them to do it very much the same way by raising their arm above their head and using this sort of pattern that we're using with this vertical strip pattern, and also to stand in front of a mirror and look for any dimpling or signs of retractions. And they're going to do this when they lie down using their 3 fingers. And so this is something that you may want to teach, and the familiarity with your own breast is something that will allow women to be able to identify potential problems much earlier. I also want to mention that while we are going to perform a male breast exam as well, it's going to be much more abbreviated, but we should never admit it because there are some men that do develop breast cancer. So we should be, examining the anterior thorax, inspecting the chest wall, noting the skin surface if there's any lump or swelling, and palpating the nipple for any lumps or tissue enlargement. And it should feel even with no nodules, and we will palpate the axillary lymph nodes. Again, male breast cancer is rare, but it is something that does occur, and it usually presents with painless, firm, retroareolar lumps. I also want to mention that gynecomastia occurs sometimes, especially with the use of steroids or some medications, but it is a benign growth of the breast tissue that makes it distinguishable from the other tissues in the chest wall and feels like a smooth, firm, movable subareolar fibrous mass. It occurs in about half of the adolescent boys, usually goes away, and it can be unilateral or bilateral. Finally, I just want to end by saying that there are a lot of things that we've talked about, like dimpling, edema, retraction, all of this. And I want to point you to the area of your book. Please go review it so you'll see what some of these abnormal findings are going to look like. That's, of course, going to be found on page 397 through, what page does it go through? About 405. And they've got some good pictures in there, so you'll know what you're seeing and what these things will look like. Thank you for listening.